Hello, I'm Dr. Simon Mears.
I am Taya Rosenbaum.
Hi, I am Molly Meek.
Hi, my name is Mark Rao.
Hello, I'm Taya Rosenbaum. I'm an Associate Chief Medical Quality Officer and Associate Chief Medical Officer of Patient Safety. Few medical errors are as vivid and chilling as those that involved patients who have undergone the incorrect procedure, undergone surgery on the wrong part, or had a procedure intended for another patient. Did you know that wrong site and wrong patient procedures were the second most reported sentinel event in hospitals across the United States last year? It's true, and I'm here to share with you how UMS has taken significant steps to ensure that we're not one of those hospitals, that we perform the correct procedure on the correct patient at the correct site every time. Patient safety leadership began process by reviewing and updating the UMS Universal Protocol and Fire Risk Assessment Policy. This policy is now clear and concise, and it establishes a standardized approach to the pre-procedural and pre-incision timeout process that applies to all our patient care settings. For instance, you may find yourself in the operating room, in the cath lab, in radiology, in an outpatient clinic, or at the bedside of a patient. The only question you need to ask yourself is, does the Universal Protocol apply to the procedure you plan to perform? The Universal Protocol policy provides all the details necessary for you to easily make this determination, so please review the updated version of the policy if you haven't already done so. The Universal Protocol is based on three primary principles. Number one, wrong procedure, wrong person, and wrong site procedures can and must be prevented. I think we all agree on this. Number two, effective communication, effective participation of all team members during the timeout is critical for the process to be effective. The protocol requires that the person performing the procedure call the room to order, which means to initiate and direct the timeout. All team members must stop what they're doing and engage in the timeout, introduce themselves, share their roles in the procedure, and actively participate in the timeout process. Every member of the team present is given the opportunity to speak up with concerns. The procedure does not begin until all issues are resolved. And number three, 100% compliance with all aspects of the timeout process must be met to achieve the goal of preventable patient harm. That said, we all know that a policy is only as good as its implementation. An effective implementation requires not only a clear understanding of the process, but also communicating and understanding performance expectations as well. It is our goal that through the following presentations of the timeout process, you will come to understand that from the operating room to bedside procedures, this 60-second pause could very well save a patient's life. That's really all the time it should take to perform a timeout, just 60 seconds to pause before the start of a surgical or non-surgical invasive procedure in order to bring focus to the need to verify the correct site for the correct procedure that is about to be performed on the correct patient. We must all join together and commit to the standard pre-procedure timeout process. This intentional pause will ensure we keep the patient safe every time for every procedure performed at UMS. Remember, make time for the timeout.
Hello, I'm Dr. Simon Mears, a physician in orthopedic surgery at UAMS. The procedural timeout is an intentional pause led by the surgeon, where all surgical team members give pause to verify the correct patient, the correct procedure, and the correct procedural site prior to the start of the procedure. The following simulation will demonstrate our process for procedural timeouts, where each member of the team has a responsibility to patient safety to participate in the timeout and to speak up for any patient concerns. Okay, let's begin our timeout. I ask that you bring up any questions, concerns, or comments at any time during the timeout, please. This is Kathy Doe on the table, and we are going to perform a right total knee replacement. The right knee is marked. Does everybody agree?
Yes. I agree.
Now, if everyone would please introduce themselves.
I'm Shamira, circulator.
I am Taya, anesthesiologist.
I'm Alan, nurse practitioner.
Whitney Scrub.
And I'm Simon, the surgeon.
All right, we have Miss Kathy Doe, date of birth 6/3/41. She has no known drug allergies. She is consented for a right total knee arthroplasty and any other indicated procedures with Dr. Mears and team. She is also consented for blood. We have sterile fluid on the field. Fire extinguisher is near the door. Antibiotics, she received 2 grams of NSAID, 1 gram of TXA. We have SCD and TED hose on the non-operative lower extremity, and imaging is available. Does everyone agree?
Agree. Scalpel.
Hello, I'm Mark Rao and a member of the vascular access team at UAMS. I have found that preventing wrong patient, wrong site, and wrong procedure errors depends on a combination of system solutions, strong teamwork, and a safety culture, and individual vigilance. As most of you have been made aware, we have updated the UAMS Universal Protocol and Fire Risk Assessment Policy. The policy now provides a clear, standardized approach to the pre-procedural and pre-incision timeout process, and it applies to all of our patient care settings. This includes performing procedures at bedside. I want to encourage everyone to review the updated version of the Universal Protocol policy. When our team performs procedures at the bedside, I may not need an extra set of hands, but what I do need is an extra set of eyes and ears to help me verify the essential elements of a timeout process before I start the procedure. I want to ensure the correct procedure is being performed on the correct patient at the correct site every time. So what does the pre-procedure timeout process involve at bedside? A very good question. I verified the same elements at the bedside as those addressed if you were doing them in the OR or outpatient clinic or in a specialized procedure area like interventional radiology. But how do I verify these elements of the policy when I'm typically carrying out these procedures alone? Another very good question is raised. I first have to find a member of the healthcare team on the unit. Hopefully someone is close to the proximity of the room where the procedure is being performed. This can be a provider or a bedside nurse. Together, we can conduct the timeout. We will communicate and agree that this is the right patient, the right site, the right procedure to be performed. I also verify that I have assigned consent and that I have all the necessary equipment at the bedside to safely perform this procedure. I do not start the procedure until all questions or concerns raised during the timeout were resolved. This intentional pause prior to beginning the procedure, where the focus is on verifying the timeout elements that are so critical to the safety of our patients, takes as little as about 60 seconds and ensures that we are doing everything possible to eliminate wrong site, wrong patient, and wrong procedure errors here at UAMS. We all have a responsibility to keep patients safe and to advocate on their behalf by ensuring we perform an effective timeout. Our patients count on us to keep them safe, and Team UAMS is not going to let them down. That is why I follow each step of the timeout process for every patient, every time, and every procedure. Please join me in putting patient safety first, and remember to make time for the timeout.
Hello, I am Dr. Molly Meek, and I am the Medical Director of Interventional Radiology. I have been faculty at UAMS for over 10 years. Under the current UAMS Universal Protocol and Fire Risk Assessment Policy, interventional radiology is considered a specialty procedural area. We perform procedures across a wide spectrum of disorders. We diagnose and treat cancers, as well as perform emergent life-saving procedures for trauma and stroke patients. I can assure you that before the start of every one of these procedures, my team pauses to verify that we have the correct patient, the correct site, and the correct procedure. Why do we do this? because we know that following a standardized process will result in fewer mistakes and better outcomes for our patients. Let me describe for you what the pre-procedural timeout process looks like in the interventional radiology suite. We verify the same important elements verified during the timeout process across all UAMS patient care areas where applicable procedures are performed. First, the provider performing the procedure initiates and directs the timeout process by calling the room to order. All members of the procedure team must stop what they are doing, focus, and actively participate in the timeout process. The verification process begins, and all team members present must agree on the correct patient, the correct procedure to be performed, and the correct site of the procedure. The team confirms the availability of necessary equipment, signed consent, that diagnostic and radiology test results are properly displayed, and that all other items required for the team to safely perform the procedure are present. Once the verification steps are complete, I ask the team if anyone has any other concerns or questions that we should address. The procedure does not begin until all questions and concerns are resolved. I am proud to be part of an organization where patient safety is top priority. I want to close by saying that whether you are performing an invasive procedure in an interventional radiology suite, one of our operating rooms, an outpatient clinic, or even at the patient's bedside, performing each step of our standard timeout process prior to starting the procedure ensures that we keep the patient safe every time for every procedure. Remember, make time for the timeout. Remember, make time for the timeout.